Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Hesham Toukhy. I am making this presentation regarding the vascular disease of the retina on behalf of Professor Dr. Magdy Moussa, Professor of Ophthalmology. In this presentation, we're going to discuss mainly vascular occlusions, occlusion of central retinal artery, occlusion of central retinal vein, and also we're going to discuss arteriosclerosis of retinal vessels. Let us first revise some basic information regarding the retinal vessels. We should know that the arteries are thinner than the veins. So the arteries are about two-thirds, the diameter of the artery is about two-thirds that of the diameter of the vein. Both appear red in color because of the blood content, of course. However, the artery is lighter than the vein in red color. Regarding the vascular light reflex, which means reflection of the light on exposing retina to the light of the thermoscopes during examination, it appears white along the long vessels because of the reflection from the wall. However, the artery is also brighter than the vein. When the artery will cross over the vein, the artery will cross over the vein without interrupting the blood column and the vein, without causing a deflection in the course or constrictions in the veins. Now we are going to discuss one of the important retinal emergencies, which is occlusion of the central retinal artery. Occlusion of central artery can be caused by thrombosis in the artery, embolism, or spasm of the artery itself. Thrombosis usually can happen in people with arteriosclerosis, hypertension, or diabetes. While for the embolism, the source of the embolism can come from the heart itself or from the carotid. Less commonly, the occlusion can be caused by hypertension, like patients with hypertensive encephalopathy, which will cause spasm in the artery wall, and some vascular disorders, like patients suffering from migraine, Raynaud's disease, and very rarely in quinine poisoning. As we said, one of the causes of artery occlusion can be embolism, that can be originated from the heart, in the form of calcium embolism or vegetations or thrombosis, or rarely from myxoma. When the source is coming from the carotid, usually the source comes from a theroma of the carotid that can be formed of cholesterol and fibroplatelets. Platelets embolus can cause either temporary occlusion of the artery, what can be presented in the form of amaurosis fluorescence, so the patient will complain of sudden loss of vision that will stay for seconds, and then the vision will recur again when the platelets embolus become dislodged. However, it can sometimes cause permanent occlusion of the artery with typical picture of central retinal artery occlusion. So now what the clinical picture for central retinal artery occlusion. Immediately after the occlusion, the patient will suffer from sudden painless loss of vision that can go down to even no light perception. Sudden means losing the vision within seconds. And if we examine the eye, we can find the pupil of the affected eye not active directly, but of course it will act consecutively when stimulating the other eye. The fundus has a characteristic clinical picture where the retinal arteries will appear, retinal arteries and veins will appear very attenuated, of course because of the occlusion, and the fundus will have the affection of the appearance of a milk white central retinal fundus with shaded spots in the center of the retina, replacing in the area of the fovea. The cherry red appearance of the retina, which is a very helpful sign for diagnosis of central retinal artery occlusion, is mainly caused by the appearance of the milky white appearance of the central part of the retina, but the fovea will still appearing red, so it looks like a cherry appearance. This is because all layers of the retina as a result of the artery occlusion will suffer from coagulant fibrosis and will appear white. This mainly affects the inner layers of the retina, which is supplied by the central retinal artery. However, because of the fovea is very thin and contains mainly photoreceptors, which is not affected by the coagulant fibrosis, it will still appear transparent, and it will show the underlying choroid, so it still appear red in area of white, so it will take the appearance of the cherry red. The appearance of the cherry spot in the milky white retina will happen in the early stages, in the very early stages of the artery occlusion. However, later, within a few weeks, 2 to 4 weeks, the white appearance of the retina will disappear. The retina will become atrophic, but still be transparent again. So the shaded spot appearance will disappear. However, the arteries will still be markedly attenuated, and also the veins will still be very thin. And what's new is that the optic disc will be atrophic, a type of optic atrophy called consecutive optic atrophy. So the optic disc will appear waxy pale. Some patients will become slightly lighter than others when they suffer from branch artery occlusion and not from the occlusion of the central retinal artery itself. One of the upper or lower branches of the retina can be occluded. In this case, the clinical picture will be limited to only half of the retina. In this patient, the visual acuity will be partially decreased or be variable according to the involvement of the fovea. Also, there is some presentation for a patient who have a special artery supplying the fovea called the cilio-retinal artery. When this patient suffer from central retinal artery occlusion, they will not lose vision because the macula will not be, the fovea will not be atrophic. However, they will suffer from tubular field of vision because all the retina will be atrophic except of the central part, but the central vision can still be within normal. This is the floating angiography appearance of the central retinal artery occlusion. We can see the very late filling of the arteries and the vein following injection of the dye. What about treatment of central retinal artery occlusion? As we said, central retinal artery occlusion is one of the most important emergencies that we can face in ophthalmology. This is because we have only from 30 to 60 minutes from the start of the occlusion to try to save the vision, otherwise the vision will be permanently lost because of the atrophic retina. The aim of the therapy is to reduce vasodilatation of the retinal arches so that they relieve any spasm of glucose in the occlusion, or will drive a small embolus into smaller branch so that the central retinal itself will be reopened. So the urgent management for patients with central retinal artery occlusion is done by giving them inhalation of amyl nitrate or injection of intravenous papaverine and make the patient breathe in a bag. This will increase the carbon dioxide content of the blood of the patient, which is a strong vasodilator. All these are vasodilators. Locally, we can try to do massage for the eye, which will lower the intraocular pressure to try to dislodge the embolus, or do paracentesis, which means perforation of the anterior chamber at the limbus so that the intraocular pressure will suddenly decrease, and this can help in vasodilating of the blood vessels and dislodging of the embolus, or by injection of retrobulbar acetylcholine or Prescool. However, there are some recent lines of treatment that can be done in specific centers, for example, by injection of the vasodilator materials directly in the central retinal artery under guide of magnetic resonance imaging. However, this can be done only by experts and in some specific centers. This is the early treatment for central retinal artery occlusion. However, we don't forget that this patient requires a general examination in the form of cardiological examination, because these patients are high risk of having other complications in the body, other embolism in the heart or in the brain. Now we're going to discuss another important type of vascular occlusion of the retina, which is occlusion of the central retinal vein of the retina. Occlusion of the central retinal vein of the retina occurs much more commonly when compared with occlusion of the central retinal artery. The etiology of the occlusion is not exactly clear. However, all the people with diseases like hypertension and diabetes and arteriosclerosis are at high risk of getting the occlusion. In young patient, usually the patient will have inflammation of the veins in the form of phlebitis with different causes, either viral infection, in some cases of basic disease and easy disease, or they will have increase in the blood coagulability, like in cases of dehydration or polycythemia. Local causes in the orbit can cause also occlusion of the central retinal vein, like in cases of orbital psoriasis or orbital hematoma. Now, what about the clinical picture of central retinal vein occlusion? The typical presentation for patient suffering from central retinal vein occlusion is rapid diminution of vision that is observed mainly in the morning. This is usually because the thrombosis much commonly formed at night. Rapid diminution of vision means decrease of vision within hours, and it can be mild loss of vision if the vein occlusion of the non-ischemic type, or severe loss of vision if the type of the occlusion is of the ischemic type. So we have two types of central retinal vein occlusion. Ischemic type, when the occlusion occurs anterior to the lamina cribrosa. Here there is no collateral circulation of the retina that can compensate for the occlusion of the retinal vein, resulting in severe symptoms and signs, and also higher incidence of complications. So in the ischemic type of central retinal vein occlusion, the symptoms will be severer and also signs when compared to the non-ischemic type. So the patient will suffer from severe diminution of vision, and the retina will show severe signs in the form of markedly congested and tortuous retinal veins, extensive retinal hemorrhage. It will give the retinal appearance of the storm retina, and edema of the rails of the retina, macula, and also disc edema, which appear as irregular edges of the optodisc. Also will be other signs of ischemia like soft exudates that can be seen in the ischemic type. The pupil for this patient will show afferent pupillary conduction defect. For the non-ischemic type, the clinical picture is less severe than of the ischemic type. Reduction of vision is less severe, and also pupil examination may not show the afferent pupillary conduction defect, and all signs of the retina will be less than those of the ischemic type, including tortuousness of retinal vein, retinal hemorrhage, and exudations, and also the edema. This is the fluorescein angiography appearance of the central retinal vein occlusion, where you will notice delayed arterial venous filling, and also there will be leakage of the fluorescein dye from into the retinal tissues. Later, complications of central retinal vein can appear. The main complications of central retinal vein that can affect the vision are chronic macular edema and neovascularization, formation of new vessels that can happen either on the optic disc, so it calls NVDs, new vessels at the disc, or it can happen anywhere in the retina, so it calls NVEs, new vessels elsewhere, or it can happen in the angle of the anterior chamber or in the iris surface, which cause rubose iris, causing neovascular glaucoma. Neovascular glaucoma is one of the severest complications that can lead to complete loss of vision in patients suffering from central retinal vein occlusion. It usually will develop within 3 months after the occlusion, so it's called 100-day glaucoma. And sometimes the vessels can be seen only in the angle of the anterior chamber, not on the surface of the iris. Neovascular glaucoma is one of the severest complications that can result from central retinal vein occlusion, especially the ischemic type. In fact, the ischemic type of central retinal vein occlusion is the most common cause for neovascular glaucoma. It can lead to severe loss of vision because of the severe increase of the intraocular pressure and the recurrent hemorrhage. The iris vessels, the new vessels can appear on the surface of the iris. These vessels will invade the angle of the anterior chamber, closing the angle of the anterior chamber, causing severe secondary angle closure glaucoma. Patient also can suffer from recurrent hemorrhage from these vessels, leading to hyphemia. Glaucoma resulting from central retinal vein occlusion, especially ischemic type, is one of the most important causes that can lead to loss of vision in patients suffering from central retinal vein occlusion. Now, what about the management of central retinal vein occlusion? We should not forget that these patients need systemic workup to control for the risk factor. They can visit the cardiologist. They can also be examined for systemic causes that can be associated with central retinal vein occlusion. We can give anticoagulants so that we under special care to prevent the complications of these drugs like heparin, and then we can continue maintaining divan. However, these drugs should be monitored by the specialist. Also, systemic steroids can be sometimes helpful if we find that the cause of the occlusion is inflammation of the blood vessels, like in cases of young patients with phlebitis. Intravitreal injection of steroids or anti-vascular endothelial growth factor can be very helpful in controlling of the macular edema and also preventing the complications of neovascularization of the retina or of the angle of the tear chamber, so they will prevent the complications of retinal neovascularization in the form of vitreous hemorrhage or traction retinal detachment, and also they can prevent the development of neovascular glaucoma. Laser photocoagulation can have a role in treatment of retinal vein occlusion, central retinal vein occlusion, where focal laser can be used for management of macular edema in cases of branch vein occlusion. However, the main rule is for pan-retinal laser photocoagulation to destroy the periphery of the retina in the ischemic type when there is neovascular glaucoma or when there is neovascularization in the retina or in the iris, to prevent complications of neovascularization of the retina or the iris. For neovascular glaucoma, in the early stages, we can give anti-vascular endothelial factor in the vitreous intravitreal injection of anti-vascular endothelial growth factor, then following by pan-retinal photocoagulation to control or to stop the progression of the new vessels. However, if the stage the intraocular still continue to be high, after that we can do surgical treatment for refractive glaucoma, including destruction of the ciliary body either by cyclotherapy or by cyclophotocoagulation. And for blind painful eye, unfortunately, we can do inoculation. Our last topic in this presentation will be discussion of retinal arteriosclerosis. Retinal arteriosclerosis can be considered a degenerative aging process that happens for all peoples. However, retinal arteriosclerosis is a risk factor for development of vascular occlusions of the retinal vessels, either the arteries or the veins. Also, the retina is a mirror of the brain. So when patients having advanced arteriosclerosis of the retina, they also will have advanced arteriosclerosis of the brain, and they will have many risk for developing of many cerebral vascular complications. So the clinical picture or the changes of that will affect the retina resulting from arteriosclerosis will mainly affect the arteries, because the materials will deposit in the muscular layer of the artery, changing its normal appearance. The earliest change will be a change in the vascular reflex of the artery, so it will be appearing white. Also, the arterioles will have appearance called copper wired appearance, where the arterial reflex will appear slightly yellowish. This will be later converted into the silver wire appearance, where the arteries or the arterioles will appear slightly white when there is a severe deposition of the materials in the muscular wall of the arterioles. Also, there can be changes in the course and diameter of the vessels in the form of slight tortuosity, attenuation, or irregular diameter. With advanced stages of the arteriosclerosis, the vessels can show sheathing due to fibrosis of the vessel walls. Other important findings and can be very helpful in diagnosis is the arteriovenous crossing change. The changes that will appear at the area where the artery crosses the vein. The most important are what's called gun signs, deflections, and banking. As we said, the changes that happen at the arteriovenous crossing is very helpful in diagnosis of retinal arteriosclerosis. Normally, at the arteriovenous crossing, the venous blood column, the blood in the vein, is not interrupted by the artery as it crosses over the vein. However, in arteriosclerosis, because of the rigidity of the arterial wall, some signs will start to appear. The most important are Gunn's sign, what's called necking, where part of the venous tissue, there is obscuring of the parts of the vein at the area of arteriovenous crossing. Presentation at the area of a crossing of the artery over the vein, there is part of the vein that's not visible. It's called gum sign, or obscuring of the veins at the arteriovenous crossing. Is deflection. Here the veins try to avoid the artery, so that will lead to decrease the complications from the arteriosclerosis. Deflection can be either in vertical, it means that the vein will make U-shape arch avoiding the artery slightly deeper in the retinal tissue, or it can be lateral. It means that the vein will cross the artery at right angle instead of crossing the vein obliquely. All of this is to decrease the area of contact between the artery and the vein at the area of crossing, so that it will decrease the incidence of complications. Other sign, which is called the banking, it means slight distension of the vein before it crosses before the site of crossing. Slight distension of the veins at the site of crossing is called the banking of the retinal veins, which are a sign of the arteriosclerosis. Presentation, we can find the deflection types, however, either the U-shaped type or the lateral deflection. Thank you very much for your attendance. If any questions, please don't hesitate to contact me.